Good afternoon, everyone. I'm Deborah DeBruin, and I direct the Center for Bioethics at the University of Minnesota. And I want to welcome you to today's Ethics Grand Rounds. We're fortunate to have with us today Dr. Jennifer Pra, who is going to speak to us on identifying and addressing gaps in health outcomes using the health capability profile. Before we begin the talk, let me briefly do an overview of some housekeeping items. Next slide, please. So if you have questions for Dr. Pra today, please use the Q&A function, which you'll find at the bottom of your screen, to type in the questions. We will hold all those questions for the end of the talk and have a robust discussion then. But you can enter questions in the Q&A at any time. If you need to clarify or follow up on your question, you can do that in the Q&A function as well. Please do not insert your questions in the chat. We're going to reserve the chat function to address technical issues. So if you have technical issues today, with they will manage those privately with you through that function. Next slide, please. I want to thank our co-sponsors today. The center partners on all of the events that we host, and we are really grateful for the support of these programs. The Center for Global Health and Social Responsibility, the Interdisciplinary Center for the Study of Global Change, the School of Nursing, and the School of Public Health. Without further ado, then, I'm going to introduce today's speaker, Dr. Jennifer Pra, and I'm just going to do a very brief introduction here so that she has plenty of time for her remarks and we have plenty of time for robust discussion. Dr. Pra is Sen Professor of Health Equity, Economics, and Policy at the School of Social Policy and Practice at the University of Pennsylvania. She is a leading global scholar of domestic and global health policy and public health. Her work is very influential and important, and we are really grateful that she took the time from her very, very busy schedule to be here with us today. Dr. Pra, at this point, I am going to turn it over to you, and I'm just going to note to folks that your full bio, your full, very impressive bio, is linked to the chat so that they can learn more details about your work. Thank you for being here.
Thank you so much, Deborah, for that incredibly generous and kind introduction. I'm very excited to be here too, and I'm looking forward to the engagement. I'm going to share my screen, and because I have a PowerPoint presentation that I'm going to be going through with you. And remind me again how much time I have.
Probably 40 or 45 minutes, and then that'll be plenty of time for discussion.
That's what I understood. I just wanted to confirm. Great. Okay, so I'm going to share my screen now. Okay, is that working?
It looks perfect, yes.
Great, okay. So I'm going to be talking about applying the health capability model and profile. This is joint work that I have done with Myriam Kost, Kion Young, Mohamed Baji, Alduama Diallo, and Sylvie Boyer. And I'm just delighted that we've had such an effective collaboration. It's been just wonderful. Just by way of outline, the health capability model and profile is what we're going to look at first, why the health capability profile, and then we're going to go through the empirical study of chronic hepatitis B in rural Senegal, how we empirically study the health capability profile, and then we'll look at a few individual case studies, how actually the health capability profile works. So the health capability model and profile, why the health capability profile? So health capability is the ability or the power to perform with, Just trying to move this over. There you go. With the potential for achieving desired ends, it entails aptitude. The important thing is it's a cradle to grave concept. It's through the life course. It's a lifelong set of abilities and conditions that we hope will enable optimal health. Health capabilities are key strengths that result from individual and societal commitments of human, financial, and physical resources with the goal of helping people thrive. So it's rooted in this idea of thriving and flourishing. Differences in health capabilities help us understand why, for example, personal skills and determination or health beliefs alone are not enough. Why people with even the best external conditions can still have poor health, and also why a narrow biomedical model of disease is insufficient. The health capability model is a model of dynamism, interactivity, and multidimensionality. And that's thinking about health in the context of flourishing. Where the circles overlap in this model diagram represents the way that individual and social factors interact to create health capability. And health capability is essentially a confidence. It's an ability to be effective in achieving optimal health, given biological and genetic disposition, intermediate and broader social, political, and economic environments, and access to public health and the healthcare system. The health capability model versus other models. So other models tend to be linear in the sense that there are one-to-one associations among different variables. So even when there are interactive terms in a model and one controls for a number of variables, we're still looking typically at a one-to-one association. Reductionist models examine more simple relationships first and then sum those subcomponents. And such aggregated forms can be very difficult to interpret and really understand what's going on with the full picture. A health capability model is a more flexible and analytical approach. It accounts for both internal and external influences at the individual level. It allows for contemporaneous multiple relationships among factors. And its overlapping feature offers more of a nuanced and sequentially iterative and interactive, dynamic, and multidimensional understanding of the optimal conditions for people to be healthy. So this model reveals heterogeneity in the influence of irreducibly social goods and experiences on the individual. And then also the individual's experience influence on society. So that's part of the dynamism there. The health capability model is, we believe it's effective for longitudinal, intersectional, and multisectoral policy and institutional analysis and design over time. It allows for heterogeneous relationships, as I mentioned before. It's this idea of capability capital. So it's interpersonal, it's personal, interpersonal, institutional, and structural capital that we're trying to build to create these conditions. It aids in addressing problems of the lack of information on the direct impact of external factors by measuring a different construct, health capability. It incorporates external factors at the individual level and impacts of individuals on society rather than trying to draw inferences about individual health based on group characteristics or macro level characteristics. So the health capability model is the sort of broader structure, and I showed you the diagram, and it's operationalized into a measurable profile and index, and that's called the health capability profile. The health capability profile comprises 15 different health capabilities, which encompass 49 separate health functionings and agencies. The profile snapshots and tracks health capabilities development. The goal is for each and every person to reach their highest health potential, their full health capability. It provides a full pictures of a person's lived experiences and their journey to reaching their health and functioning potential. Here is, and this is from our website at the Health Equity and Policy Lab, And this is our logo of the lab behind me. And these are the different kinds of capabilities we're talking about. So, and we're going to, look at these. The first there's internal and external capabilities, as I mentioned. Internal is health status, health functioning, health knowledge, knowing about your health and knowing how to be healthy, health seeking skills and beliefs, self-efficacy, so believing in yourself and your health values and goals, so valuing health, self-governance and self-management and perceived self-governance and management to achieve health outcomes. Still internal is effective health decision-making, so making good decisions about health. Intrinsic motivation, so being self-motivated towards health. Positive expectations, having positive expectations about one's health and flourishing. Social norms, cultures of health and expected behaviors in society. That's when we start looking at external capabilities. And social networks and social capital for achieving positive health outcomes. So connecting to others for health, which is an important aspect of our ability to be healthy. External capability 11 is group membership influences. So this is health norms of your social groups. Material circumstances, having material circumstances that support health. Economic, political, and social security, general feelings of security, utilization and access to health services, receiving health care when needed, and enabling public health and health care systems, effectiveness of the health systems. So, for example, internal capability 4, that is how we value health and what kind of goals we set. So it's a kind of agency of valuing health-related goals, valuing lifestyle choices and behaviors, and then the ability to recognize and counter, for example, damaging social norms or adopt positive social norms. Health values and goals is the internal capability of valuing one's health. It includes health-related goals and health-promoting behaviors. Health-related goals refer to objectives one has for one's health, like healthy cholesterol levels and weight. An example of health-promoting behaviors and lifestyle choices and behaviors is regular exercise, a healthy diet, and an active lifestyle. This capability also includes the ability to recognize and counter damaging social norms, as I mentioned, that undermine health, and also the ability to, again, recognize and adopt positive social norms. So what we do when we look at the health capability profile is we sort of say, why is it important? What does it look like? And how do I do it? It's important because of health values and goals we live in a world of finite resources, including our own resources. Health will not be achieved if it's not prioritized. So this is the priority of health. And it allows us to understand that health is central to a good life and should be treated as such. And health values and goals ensure that we see what is truly important in life as we pursue it. And then what does it look like? Well, someone with high internal health values and goals capability expresses their values through words and actions. They may speak positively of health-related goals and healthy lifestyles, choices and behaviors, as well as explicitly counter these social norms that damage health, and promote positive ones and internalize positive social norms. They will have a high priority in a person's life, including how they structure their own pursuits, their free time, daily schedule, and short-term and long-term priorities and plans. And how do I do it? Well, health values and goals can be continuously developed. Questions to ask oneself might be, why is my health important to me? How do I practice and honor that in my daily life? What resources am I committing to my health? What are some goals I can set that will help me become healthier? What is my lifestyle saying about what matters to me? How might I change some of my lifestyle habits to have health as the top priority? What are some of the social norms that detract from my health? And how might I respond to them? How might I put myself in a position to benefit from social norms? So these are the kinds of things we think about with this particular internal capability. And we have the different capabilities on our website. We go through this kind of a structure of thinking about it, for each one of the capabilities. And here's an example of an external capability, social norms. I talked about that. I think it's a really important one. So this is cultures of health and expected behaviors in a society. And these, are functionings like the extent to which health norms are scientifically valid and evidence-based, the extent to which health behaviors and health-seeking skills are viewed favorably or unfavorably, the extent to which a health behavior is adopted by a majority or a minority of the population in a culture, and then by whom. The extent to which discrimination or anti-discrimination is the dominant norm in the provision of healthcare and public health services. Norms about decisional latitude or power in familial and social contexts, society's ability to recognize and counter damaging social norms and promote positive ones. And so social norms are an external capability that encompasses a variety of health promoting norms across different social domains. A strong social norm capability includes scientifically valid and evidence-based health norms. Health behaviors and health-seeking skills are viewed favorably. Health behaviors are adopted by most of the population. Society is able to recognize and counter damaging social norms. Social norms in the provision of healthcare and public health services ameliorate these disparities in access, and norms about decisional latitude or power in familial and social contexts are conducive to each person's health agency. So this is the kind of thing we're looking for in this external capability. Again, why is it important? Again, I think this is a very, very important norm, but we'll talk later about external capability. We'll talk later about the structure of the profile and how we figure out which may or may not be more or less important in particular contexts. Social norms are important as an external capability because they shape our beliefs and our actions. What we consider acceptable, normal, valuable, and important, what is expected in order to belong to society, living in a society where health is scientifically understood, widely regarded as important and supported, institutionalized as a priority, and where people are encouraged and sustained in being active agents of their own health. That's a critical capability for one's health. What does it look like? A society with a positive social norm, external capability, will demonstrate, again, scientifically accurate health norms, such as the social norms of childhood vaccines and immunizations, respectful and anti-discriminatory expectations about behavior, and empathy and care towards each other to thrive. Seeking and receiving vaccinations, for example, are viewed positively as in social circles and professional settings because they save lives and they're important for our health. And all of the population is vaccinated and immunized because that's what's healthy for oneself and healthy for society. So anti-discriminatory service provision and practices are important for all communities, especially underserved populations, and children's health is it's important to understand children's health and that it's not put at risk due to power imbalances in parent-child relationships, unscientific beliefs of parents, for example, and then public moral norms of justice, fairness, and equity. The goals of public health and health policy are to serve everyone and benefits all. So we can develop our health capability of social norms through promoting positive health and public health and public moral norms. And that's through individuals, but as well through institutions such as the media, academia, governmental organizations, and popular culture. So the health capability profile is a flexible profile, we believe. It's multidimensional, there are individual factors, there are sociocultural aspects, there are institutional features. It's a dynamic framework. It's really in the area of implementation science, so focusing on the identification of gaps between observed health capabilities and an optimal level of health capability. And then there's a normative dimension to it. The health capability paradigm, which is what I advanced in my book, Health and Social Justice, advances principles ensuring that individuals and societies work together towards health capabilities for all. So there is an underlying normative justice dimension to the health capability paradigm, which then is the foundation for the health capability profile. So applying the health capability profile, the first is adapting the profile to the particular health condition or setting, and we'll be talking about one example today. Methods, using mixed methods, social justice, so quantitative and qualitative data collection, and then data integration. So we have flow diagrams, we have 0 to 100 health capability scores, and then that is really feeding into policy change towards health capability for all. Because obviously, if we were there already, it would really be sort of maintaining that status. So I want to talk now about the empirical study of chronic hepatitis B virus infection in rural Senegal. So this is about how we empirically study the health capability profile. Chronic hepatitis B virus infection is very serious. Over 800,000 annual deaths are secondary to CHB infection worldwide. Yet CHB-related morbidity and mortality is avoidable. The WHO strategy on viral hepatitis calls for its elimination by 2030. And this strategy relies on 3 pillars: prevention, testing, and treatment. Prevention is focused on vaccination. It's a 3-dose schedule, including a birth dose in some cases. Testing, that's key in identifying people who are chronically infected with CHB. This is because CHB infection is often asymptomatic, so we need testing, especially in early stages of the infection. Treatment and lifelong linkages to care is essential for chronic CHB patients. Complications of CHB infection include liver damage, cirrhosis, and even liver cancer. And then lifelong antiviral therapies can help avoid CHB-related morbidity and mortality. Because it's a chronic disease, there's no cure. There are major gaps in CHB management, and the WHO has done a lot of work on this. There are targets, again, for elimination for 2030. There's a testing gap, and then there's also a treatment gap. So the viral hepatitis program in Senegal is important to be looking at. CHB prevalence is highest in the Western Pacific region and in Africa. Senegal was actually the first sub-Saharan African country to set up a viral hepatitis program in 1999. The 3-dose vaccine was introduced for the 2004 cohort, and the vaccination is completed with a birth dose, and it has been since 2016. So the Minister of Health launched this decentralization of CHB in 2018, yet the testing and the care is costly and scarcely available, in particular in rural areas. And this affects about 10% of the Senegalese adult population that lives in these areas with CHB. The NAGHAR Health and Demographic Survey System is a rural area of particular interest, and this is a map of the area. It hosted the first sub-Saharan Africa hepatitis B vaccine trials. That was quite some time ago in the 1970s. It's a pilot region for the decentralization of CHB management. So there's been some testing work done, testing meaning piloting. It hosted a study offering CHB testing in the general population, and the OMBA survey, which is what we use in part in our study, on the burden of CHB infection, recruited over 3,000 participants between October 2018 and July 2019. So there are also socioeconomic questionnaires that were administered as part of the study. So the overall objective was to study CHB morbidity and mortality in rural Senegal using the health capability profile. So this is the adaptation part of that spectrum I just showed you. So the empirical research questions are things like, what are the gaps between observed and optimal health capabilities that are relevant to CHB in rural Senegal? Are there vulnerabilities that are peculiar to CHB patients, in particular in relation to entry in CHB care? What can we learn from positive examples of highly developed health capability profiles in this context? How can we inform and prioritize short and long-term policy and behavior change towards CHB-related health capability for all individuals living in rural Senegal? And then methodologically, in terms of research questions, how can we design a mixed method study that applies the health capability profile to empirically study this in a contextualized public health issue? So again, adaptation of the profile to chronic hepatitis B and to rural Senegal. So that's sort of how this profile is being used to a particular condition and a particular setting. This to CHB infection, hepatitis B transmission routes and the natural history of the disease are important. We know that there are CHB related risk factors and behaviors, obesity, alcohol use, especially hygiene, safe sex, etc., and that the prevention of CHB related morbidity and mortality is related to testing, vaccination, follow-up, and treatment. So this is really very important. It's based on many, many studies. In rural Senegal, social norms, as I said before, is a very important part of the health capability profile, external health capability. There are cultural and religious beliefs of the population, the Sera ethnic group, majority Muslim, and the importance of traditional medicine. So these are social norms that are operating in this area related to this infection. The social capital and networks, the informal neighborhood groups, extended households, weekly markets, mosque, football teams, this kind of social capital and networks that exist, material circumstances. It's a hot weather climate. Many of the roads are unpaved. It's informal work sector, and there's considerable migration. So, and then to stakeholders involved in CHB care and policy in Senegal, we've had the national level. So we had the viral hepatitis program, the Ministry of Health, the Society of Senegalese Hepatologists and Gastroenterologists, the Sarfara Hepatitis Patients Association. So these are different groups and stakeholders. And then even at the local level, of course, which is the most important in many contexts, the community-based healthcare workers, healthcare providers, the Center of Traditional Healers, Malongo Center of Traditional Healers. And this is the local context and stakeholders. So here's how we adapt the profile. This is just an illustration. It's just one, as I said, one condition in one setting. For example, when we're talking about health status and health functioning, we're looking at self-reported health status. We're looking at different health conditions. So for example, CHB-related health conditions are the status, the disease evolution, the vaccination status, and these risk factors, alcohol use and obesity, other health conditions. When we're looking at health knowledge, what we did was we looked at knowledge of one's own CHB and vaccination status, knowledge of CHB-related transmission routes, disease evolution, vaccination testing and treatment, knowledge of behaviors that are CHB risk factors, again, the alcohol use and nutrition, modes of health and CHB information gathering, healthcare providers, internet, newspaper, radio, the Patients Association. So this is the kind of health knowledge questions that we asked in these areas. Health seeking skills and beliefs, self-efficacy. So this is the belief in one's ability to avoid CHB infection or transmission and CHB related complications. The ability to acquire a CHB related skills and apply them. So learning to monitor CHB condition and avoid infection or transmission through vaccination, hygiene, and protection. The confidence in the ability to perform or abstain from these CHB-related health behaviors, such as avoiding alcohol use and adapting one's diet. We also asked, we designed a survey, and we asked different sets of questions within each of the internal and external capabilities. So health values and goals. This was your value of health in general, valuing the prevention of CHB infection, transmission of CHB-related complications, valuing CHB-related lifestyles or behaviors, change in diet, hygiene, etc. And then recognizing and countering social norms detrimental to CHB prevention and monitoring. Then in self-governance and management and perceived self-governance and management to achieve health outcomes. We looked at the ability to be in control of one's life, to set and reach objectives in general, the ability to handle one's workload within the household, the ability to control one's behaviors for health or CHB-related purposes, avoiding situations that involve alcohol, for example, the ability to seek out support from neighbors, family, obtain resources, and access to CHB testing and vaccination or treatment. In terms of effective health decision-making, we looked at the ability to use CHB-related knowledge and available resources to avoid infection, transmission, or disease evolution, the ability to weight the short and long-term costs and benefits of CHB-related behaviors and actions, including nutrition and, again, alcohol consumption, the ability to identify CHB-related symptoms, jaundice in particular, and pursue vaccination, testing, follow-up, or treatment, and the ability to make healthy choices in relation to CHB, reducing alcohol consumption, not sharing hygiene equipment. Intrinsic motivation. This was assessing strengths and sources of motivation to avoid CHB infection, transmission, or CHB-related complications, and exploring whether it is internal or external. And then positive expectations is about optimistic or pessimistic viewpoints on personal life and CHB-related health prospects. Social norms, in terms of external health capability, the social norms on hepatitis B in relation to national and international recommendations, favorable or unfavorable views on vaccination. These really matter on people living with CHB, on alcohol and condom use, quantification and characterization of people that undertake CHB vaccination and testing or adapt diet, discrimination or anti-discrimination of people living with CHB and of people seeking to access vaccination, testing, or care. For example, people with an alcohol use disorder, norms on decisional latitude or power in relation to health in general, changes in resistance to social norms relevant to CHB. So what are vaccination, alcohol use, healthcare access, social networks and social capital for achieving positive health outcomes, the ability to ask for instrumental help, and the ability to talk to someone about one's problems, including disclosure of CHB status, the existence of the Patients Association, other groups and networks to provide information related to CHB, the existence of social networks or groups of people that have a detrimental impact in relation to CHB. So these are discriminatory practices, for example. Group membership influences, so membership to any kind of community organization or informal group that may provide instrumental or emotional support, counterbalance or augment a social norm relevant to CHB. And then the material circumstances, economic activity, monetary resources, the neighborhood and one's quality of life in the neighborhood, and resources including access to healthcare facilities, water source, waste management, housing status, crowding, heat protection. Again, the climate's very, very warm. The availability and quality of food, and CHB carriers and other sources of pollution or disease in the immediate environment. And then finally, the last three external capabilities that we studied through the survey that we adapted for this condition and population and setting, focused on economic, political, and social security, the availability and quality and security of jobs, in particular for people with severe liver disease, political security, the existence of institutions, including the judiciary, for example, and elected representatives that represent the people's interests, prevent violence and criminal activity, social security, existence and quality of financial and disability protection that cover CHB-related costs, for example, utilization, access to health services, obviously that's a very important one, symptoms of CHB-related health issues, so jaundice, for example, is that recognized and treated, other serious or morbid symptoms of poor health, the perception of a need to see a health provider, the existence of CHB-related health services, again, the vaccination, the testing, the follow-ups, the exams, and consultation, and then barriers to access, so geographic accessibility, waiting times, and then an enabling public health and healthcare system, the extent to which healthcare facilities and health authorities are doing several things. Are they giving information and helping people take charge of their CHB prevention and monitoring? Are they protecting people from CHB infection, transmission, and complications? And are they being efficient in providing CHB related care and accountability? Is there accountability if not? Okay, so now we're talking about methods, the mixed methods that we've been working on. This is a social justice mixed method study. So the health capability paradigm, as I said before, is the underlying foundation. And then through operationalizing the profile, that guides the design and conduct of the research. All the stakeholders and elements of the profile are accounted for. It's as you can tell, it's very comprehensive. Individuals, the healthcare system professionals, institutional representatives. And so there's need for data on objective situations as well as people's subjective experiences. And we think that that gives a more accurate picture of what's going on with people in terms of whether or not they have the conditions for their flourishing and their ability to be healthy, or there are barriers and obstacles. So this is an explanatory core design study. The quantitative survey provides an overview and is used for purpose-built sampling of individual interviews. Both data collections are conducted at the individual level. So we had the quantitative survey, which is the gaps in CHB status, vaccination status, linkages to care in general. And then the qualitative interviews, which were select individuals, not in that larger population for the quantitative study. And we did each of the aspects of the health capability profile. We had a convergent core design, so we collected additional information on external health capabilities using focus groups and health facilities surveys. These data were collected at the group or the community level to try to, again, get the individual and group objective, subjective. All the data were integrated to try to document health capability profile in this setting, in this condition. The quantitative survey, I'm not going to go through this too much, but there were 300 households. This was participation in the study that involved CHB testing. There were questionnaires, and then there was a further examination to assess people's stage of their disease. Because I want to get to some of the later work, our findings. This is data from the quantitative survey. Again, I went through generally, but this is how we actually specifically collected the data. These are a qualitative study. We did semi-structured interviews, and then we did key informant interviews. We had open-ended questions and on the different 15 external and external capabilities. And then we had key informant interviews, nurses, for example, physicians, etc. So this is just an example of our interview guide. This is the health capability on the left, health knowledge, for example. Those are the 4 areas I mentioned earlier. And here are the kind of specific questions that we asked. I'm not going to go into that detail right now. I can come back to this slide if people have questions. And then our health facility survey was an inventory of resources available for CHB management. We did this for all the facilities, and we have a microcosting methodology to document the availability of youth resources. Then we have data integration. I'm going to talk to you about the data analysis plan very quickly. I think I have, how much more time do I have?
You're good. You have, 10 or 15 more minutes.
Perfect. Thank you. That's what I thought. Data analysis plan is multi-layered. So the first layer is the individual level, as I mentioned, individual health capability profiles. And then we're actually in the process of the data analysis, conducting cross-cutting analysis of the 15 different health capabilities at the area level. Our data integration strategy draws from a synergistic approach. We're adopting a positive equal value of quantitative and qualitative data. we're producing quantitative results and qualitative results as well, and mixed methods results. And our mixed methods analysis is using a 0 to 100 health capability scoring system, as well as these flow diagrams at the individual level. And I'm just going to show you like an example of that. So this is our synergistic approach. I just want to get through. And then here's how we're going to do the indicative scoring, and, sort of thinking through how to get from, what we have to a 0 to 100 score. And here's the idea. I want to spend a little time on this because I think it's just really interesting. We're learning so much, and it's such a great experience. So if there's a maximum score of 100, that's like the optimal level. Remember, we're talking about optimal conditions and experiences. So that corresponds to a normative but realistic and attainable goal. We're having independent scores by two different researchers, and so we're looking at stages of capability development is how we've basically done this. So there's no capability there, that's 0. There's a basic level of 1 and 2, so that's sort of, there's 2 steps there, sort of, basic, but that first step, and then a more advanced basic level. Then there's sort of 2 intermediate steps that were corresponding with 40 and 55. And again, we're really trying to do this in a very stepwise fashion, sort of an intermediate 1 and intermediate 2. Then there's an advanced level that someone may be at in terms of their capability development, and that's 1 and then 2, and those are like 70 and 85, and then optimum would be 100. And so when we think about this, like an internal capability, an individual is at a naive or novice or advanced beginner level at those lower levels of the scoring range. They're at an autonomous, competent, and experienced level, sort of at the middle level of the range. And then they're really at a proficient and expert level at the higher level. That's sort of the way we're thinking about it. And really excited about your feedback. External capabilities, these are conditions under which people are trying to achieve optimal health. So unpropitious, non-hindering, promising, propitious is and favorable and facilitating is sort of the middle. And then there's enabling and fully enabling environments, sort of what we're after. So yeah, we're really interested in this. Love your feedback if you have any on this, because we're really engaged in it and are finding it just a really interesting process. All right, so analysis and expected results. Like I said, we're doing the flow diagrams, and I'll show you that in a minute. And then the 0 to 100 health capability scores. And that's how we're trying to work through and figure that out and use that in a scale-wise capacity. And we just think these are tools. We're trying to think about presenting the results as tools. I mean, they are results, but as opposed to results. And let me just tell you what I mean by that. So they're helping to integrate this quantitative and qualitative data as part of the profile. There's no right diagram or right answer. It's really, it is that what we're finding. So in terms of that kind of validity and reliability, we're obviously shooting for that and advancing that. But we recognize that these are individual to the person. So scores at the individual level, we're trying to recognize and identify strong or marginalized profiles and parts of profiles. And in terms of the health capability dimensions, we're identifying areas of shared marginalization or strengths that we can help understand and inform and prioritize policy. So the profile as a whole is really what creates somebody's ability to be healthy. And the goal is, again, for everyone to reach his or her their potential. This is our analysis and ongoing work. Can just skip through that, I think. And then let me just end with the individual case studies. So how does the health capability profile actually work? And here's how it works. So for example, this is one of the participants. This is the number. This is a 60-year-old man who has not visited a health center for CHB management, and is vulnerable to CHB related morbidity and mortality. I'm just going to put it all together. Okay. Oops. There we go. Okay, so let me move my thing around here. Okay, so these are our diagrams. So the shortfalls are on the left, and we have red arrows that show relationships among the different capabilities, health capability dimensions that are shortfalls in the shortfall area. And the optimas are on the right, and the green arrows are arrows that are showing the connections when there's a more of an optimal level. So in decision making, the person's not looking for information. In terms of self economic and social and political security, the person's self-employed with no insurance. In terms of intrinsic motivation, there's a low internal motivation, and there's a pressure by family. In terms of CHB, there is, in terms of functioning, there's CHB plus, but there's also daily alcohol and tobacco. There's difficult sleep. There's a recent sickness. In terms of healthcare access and utilization, there's been a CHB checkup, but not referred yet. In terms of health-related values and goals, health is valued, but not the top priority. Work is the top priority. In terms of material circumstances, this person is the breadwinner in a relatively poor rural agricultural CHB plus household. In terms of knowledge, there's a low level of knowledge, and the status is undisclosed. Now, some of the optimas, group membership is sort of in the middle here because there's no adverse group membership that's documented, but that's sort of more of a neutral. There's, in terms of governance, there's a high perceived freedom. There are attempts to reduce daily alcohol consumption, for example. In terms of enabling healthcare system, there are healthcare professionals that have helped this person and this person's family. In terms of social capital and networks, there's a supportive family that encourages and prioritizes health. In terms of belief and self-efficacy, there's an optimal perceived competency. And in terms of positive expectations, this person is very optimistic. So this is a way that the profile works in these diagrams, are very flexible. I'm actually teaching a course on the health capability profile now at Penn, and the students are remarkable in working with the health capability profile and creating, for example, these diagrams in case study situations. It's really fun. Here's another example of a person, a different participant in our study, a 29-year-old woman who has been going to all of the planned visits for CHB management, has been successful in avoiding CHB morbidity so far. And let's look at this person's profile. I'm just going to go through it, put it all in one. Yeah, we go. All right. So this person, again, shortfalls are on the left, optimas on the right. Shortfalls are connected with red arrows. Optimas are connected with green arrows. So on the shortfall side, we have material circumstances, which is it's a poor agricultural household. In terms of economic, social, and political security, there's no insurance and no pregnancy leave. Social norms, the stomach aches that are caused by worms and the traditional medicine. Knowledge, there's low knowledge. And group membership, there's no specific group membership, that's sort of in the middle. Positive expectations, hepatitis is worse than malaria is the thought and the expectation. In terms of functioning, there's good self-reported health, there's ongoing hemorrhage and pregnancy. And there's social capital and networks that are supportive, but there's unemployment among a family member. In terms of beliefs and self-efficacy, there's a belief in the ability to seek and obtain medical care. In terms of healthcare access and utilization, there's CHB follow-up in local facility, but that might be discontinued. There's decision-making. The person seeks and follows professional advice. In terms of health-related values and goals, health does take precedence. In terms of intrinsic motivation, there's always acceptance in terms of healing and the person's own decision. In terms of governance, there's ability to organize and put health first. And in terms of an enabling healthcare system, the hospital is really the first choice for this person. They feel better after visiting the doctor. So this is just another example of the profile. So I'm going to end pretty soon. There are some cross-cutting issues that we're learning from this study that I just want to highlight. There tends to be a low knowledge of CHB disease management and prevention. There tend to be detrimental social norms regarding CHB and CHB care. There tends to be a precarious material circumstances and limited monetary resources. There tends to be an absence of health insurance, Social Security, and poor job quality. So these are some of the things that when we aggregate or when we understand the results in their cumulative capacity, these are the kinds of things that we're learning. There are some main strengths, though. The governance and self-management area, individuals are able to multitask, prioritize health, and seek and obtain resources when the needs arise. There's a perceived competency and self-efficacy among people. There's enabling healthcare systems in terms of perceived quality and agency, building from local dispensary. And then there are different individual vulnerabilities and strengths for different individuals. And so that's what is helpful in terms of applying the profile. Okay, so let me just say, how do we use it? And then we'll end. How do we use it, for example, to use the profile to promote health capabilities? Well, we can think about it in terms of these different kinds of approaches. Community-wide sensitization and information on CHB to improve knowledge and foster evidence-based social norms and practices, and motivational viewing, support to develop health-related goals, efficient decision-making, and intrinsic motivation. Positive outreach in terms of activities conducted by dispensaries and staff who are well-known and trusted. Institutional reforms to offer universal health insurance and job protection for self-employed individuals, and improving material circumstances and living conditions. Expanding the associations or groups that people are involved in, and the positive support that they can provide, and to help in terms of CHB management. And then more of a comprehensive approach to health is really addressing alcohol and tobacco use and some of the sleep issues as well. But the alcohol use is a very core part of this. Okay, so I think I'll end there and open it up for questions and comments. Look forward to hearing from you all.
Thank you. So before we start the sort of digging in on the questions, let me just mention to people that we will be making an evaluation available afterwards, as we always do. The link to that will be in the chat, and I believe will come to your email if you, given that you all have registered for the event. If we have students here from the biomedical engineering program or from the health professions programs who want ethics or interprofessional education credits for attending this seminar, there will also be information in the chat about that. So, and let me remind you, if you have questions, and I see some people already do, insert them, if you would, type them into the Q&A function that you'll find at the bottom of your screen. So let me start here and just say that this is a really sort of interesting and I think very important kind of model that you've got. You know, we talk a lot in public health and in public health ethics about the right to health, the right to the enjoyment for the highest attainable standard of physical and mental health. And it's so difficult, I think, to unpack what that means. And I think and I'm curious to know the extent to which you all think about it this way. This model strikes me as a really useful way of trying to understand that idea of what is the highest attainable standard. Taking into account both those sort of individual and social contexts. And again, in my experience, a lot of times in conversations in public health ethics, when you start to talk about the social determinants of health, people object that, but there are also, individual determinants of health, as if, and it seems to me that a lot of the conversation is sort of premised on this idea of a false dichotomy. We should be talking about the individual stuff, or we should be talking about the social stuff. But really, the reality is that what the influences of someone's highest attainable standard of health is complicated, and it's a mixture or of an interconnection of like all of the above. And it seems to me that that's what you are really providing us a model of here. And I wonder if you want to just at that very high level sort of comment on that.
Thank you, Deborah. That's a really, really great and challenging question. Well, the health capability paradigm has been, I believe, discussed in the literature in terms of framework for the right to health. And so your question is very apropos, because this is sort of, as I said, the health capability profile then is really steeped in the health capability paradigm and trying to operationalize that, conceptualize and operationalize it. So yes, I do think that makes a lot of sense. And it's good just coming from you as an observation after seeing now it right operationalized and put into practice. And so I think that could be very interesting. I also agree with you that there has been a false dichotomy between the social determinants of health on one part and then the individual factors on another part. And it isn't one or the other. It isn't either or. It's both, but it's also not both in a linear or just a straight up aggregative way, as I tried to identify at the beginning as some of the concerns. And I think it is iterative. I think it's interactive. I think it's dynamic. I think it's over time. When I teach this course on the profile, it's exciting to be thinking a lot about the cradle to grave aspect of internal and external capabilities and how it maps with what we know about the brain, for example, especially those first 26 years of the brain, our personhood and the brain and its development and what's going on. And so, if we can start thinking about what we want, right, and what the conditions are, and then how to go about it for everyone, it's equity, it's justice, right, then I think it could be very exciting to try to put this into practice and policy, as you were just suggesting. Thank you.
So there are more questions about that in the Q&A, so let me dig down into the things that our participants are asking. Interesting question here from a colleague of mine at the center who asks, how does the health capability model engage with different concepts of disability? The medical model would see disability as a problem of the body, therefore something that should be solved within the individual body, while the social model sees disability as a problem of community and access, and solutions lie in social and environmental change. There again, you sort of get to that external social factors versus individual factors picture. And I'm wondering if you can talk about how the model plays out with respect to disability in particular.
Thank you so much. Is that
Jamie?
Jamie? Okay. Yes. Thank you so much, Jamie. It's a really excellent question. And I think it follows very nicely from the last question that, it is It's both. It's, you know, but it's more along the lines of trying to figure out if somebody has a particular condition, you know, which may have been genetic or biological or developed or occurred through the lifetime. That's what the model and the profile is trying to do, is say, okay, that's it. You know, that's there. Let's understand it. Do we have the internal capabilities to know the health status, you know, the status of it, the nature of the condition, the knowledge about it, the decision making about, you know, all that. Given that, you know, how do we create the conditions for that person, given their particular condition, for optimal health and flourishing? That's what it is, and advancing that. And it does include the external capabilities. It does believe that social norms and social environments and material circumstances are essential for that enabling of optimal health and flourishing. Yes, thank you.
So I just want to follow up real quickly on that. Because just for context, I've been working a lot over the course of the last couple of years on COVID. And it seems to me that as you were talking, and I know that your case study is about, you know, CHB in Senegal, but I was thinking in my mind, how does this apply to COVID? And it's not, it strikes me, and I wonder if you agree with this, that the model doesn't necessarily apply only to individuals who already have a condition in the way that you just described in response to Jamie's excellent question, but you know, to particular risks as well, right? I mean, it seems to me that the factors that you outlined, sort of individual and social, are all hugely important in terms of our thinking about COVID response as well.
Yes.
Whether you have COVID or not, right? Yeah.
Absolutely. Absolutely. The model can be used for prevention. It's
Yes.
a cradle to grave model, and it's an intergenerational model. So a child that's born we possibly have knowledge about, right, what their potential conditions are, right? And so, you know, there's an intergenerational and there's a cradle to grave component to it. And, you know, I'm hoping that it will also help us to collect so much data and information about individuals and populations, that we're going to be able to come to some sort of best practices and policy prescriptions, not algorithms or blueprints, but, you know, that are, generally speaking, what we're learning work in terms of the optimal conditions for people's optimal health and flourishing. I believe that we can learn that if we are intentional about it, right? I really do.
I agree. Let's dig down on each of those aspects a little bit. We've got some questions in the Q&A about the individual questions, as well as about the more social or policy or public health kind of questions. So one participant asked, will individual study participants receive their individualized profiles as a tool for personally increasing health capability, or is there a community follow-up plan or debriefing plan for the research?
That's great. Thank you so much. Is that Kirk?
Yes.
Great. Yes, that's a great question. Another really good question. I would like for, you know, this is our first time doing this. So, you know, we're figuring this out, but my idea of our idea generally, the people we collaborate with and things like that, I believe is that this is a tool that can be used for individuals at the individual level, right? I mean, when you think about it, like, you know, sort of with providers, you know, and there's a database and you have your own sort of system of information that we've gathered about an individual's particular health capability profile. And I would hope that it would really be helpful for the individual, to use, and then groups of individuals to use and to advocate for. And in here, I'm talking about using collective health agency and individual health agency, not in a zero-sum capacity. Not in a zero-sum capacity. So it's not, AIDS groups against cancer groups, or, it really is important that we think about equity and justice. And we're in the year 2022 now. We have a lot of advancements in financing and economics and production and manufacturing that we've been able to figure out how to do a lot of work so that we have resources, and that scarcity isn't quite the problem that it used to be. It's more policy, it's intentional decisions, right? And this can be a tool individually as well as collectively to help us hopefully make better policy decisions towards equity in people's health capability. Yeah.
So then could you talk a little, your answer to that question provided a lovely segue to the next question about how you would use this information to develop policy recommendations.
Great. And who is that? Who is that from?
Chris.
Hi, Chris. Thank you. Okay. Yeah. So how would we, right. So
Oh, you're muted. Dr. Pra, you're muted.
got it. Okay. Sorry. I apologize. So here's, I skipped this because I was moving through, but this gives us an idea of, again, what the profile looks like. It's unique to each individual at a point in time. But again, I would envision we keep it in a longitudinal sense as well, where we're gathering data over time. And that's going to give us a lot more information. It's going to enable us to make better decisions. It offers multi-level analysis. So you get, like I said, we have the strengths and the vulnerabilities at a glance, and there's details, there's information that we can get and understand about the different levels of analysis. And then there's the dynamic nature of it, and the nuanced nature of it. And so with what it can do is, I think it reveals these causes, and it better describes what's going on in this very complex situation. I think that the illustrations that use webs and things, that's really great. Those are wonderful. But I think this is really what we're hoping this will help us do, is really get to the complexity and really understand what the leverage points are in a particular condition, in a particular time, and a particular place, with a particular population, and really try to understand that at the granular level, as we said. And then we can also still aggregate it up for policy purposes. So we're going to have cumulative effects at the individual level, but also at the population level. The other thing is, I believe it really helps with heterogeneity. So that's why I showed you those two case studies. Well, we have multiple. We actually have another paper coming out where we have dozens of case studies that we've used. Now, we didn't collect our own data on this one, but we're trying to demonstrate the profile and how it works, and how you can see these heterogeneous effects. So, for example, we have profiles of particular conditions where quite well off people in terms of material circumstances have very significant deficits in terms of their overall ability to be healthy. And some of it's the internal part, some of it's the social norms in a very extremely wealthy and well-resourced environment that actually can be damaging to, for example, mental health or substance abuse or things like that. So we're hoping that the profile will give us some more heterogeneity, and of course, certain levels of socioeconomic status are detrimental and problematic, but it hopefully will help us understand why and what's going on there more specifically. It also helps us understand vulnerabilities and resiliency. So hopefully we can see at the individual level, my goodness, this is a remarkable situation where a person has very high levels of internal capabilities, right? Even in the context of maybe some deficits in the external side, or but both. This will just help us with the vulnerabilities and the resiliencies, and hopefully, again, we'll learn more. And then it highlights strengths and positive examples. So there's a kind of a accumulation of positive examples, I think, that we can come from this process, where we learn what works, really what we're, I mean, because that's really what I'm interested in. How do we get there? What works, and how and why? Yeah.
Yeah, because the end goal is optimal health, obviously. So yes, that is obviously what matters. You are right.
Yes, and for everyone. And
right.
For everyone. That's the thing. That's the thing. And it's not an average. This is not equity. So it's again, the health capability paradigm is the basis, the foundation. It's not an average, right? It's not an average. It's for every person, every single person. Yeah.
That's a very interesting sort of perspective on equity. I think important for us to consider. Let me ask you just a few more questions, if we can manage within the time. One is sort of issues. This is a question from a colleague named Andrew, who wants to know if you can comment on those social forces that are sort of beyond the local context. So he says, can you comment on global forces out of the reach of those rural individuals, the golden oil trade, climate negotiations, World Health Organization policies, et cetera? What role can those play, or do they play in the model?
Right. And which question?
This is from Andrew Jameton.
Andrew, thank you. All right. What role do these larger organizations and institutions? Well, the macro environment, the global environment, impacts the national environment, the regional environments, which impact the national environments, which impact the subnational, and then the community and, provincial, state, community, local. So, I think if COVID has taught us anything, it's that we are interconnected globally. And so the idea that we would have some kinds of global governance and structures to help us understand what we need to do about that connection is important. I wrote a book, Global Health, Justice, and Governance, on that kind of a idea, grounded again in this notion of the ability to be healthy for everyone. It's an ambitious question. I don't have an ambitious answer, but it is necessary to understand the global context and the global institutions and policies that are impacting, all the way down. This is an individual instrument. I mean, it's an individual health capability profile is at the individual level. It's really gives a lot of agency, and it gives that space for the individual, while recognizing that individuals are connected. We're connected to each other. Now, for example, like even in the profile, we could see possibly a group influence, or a particular patient group or something that may have a global a context. That's through the health capability profile at the individual level. But and I was before describing how these institutional and policy structures have an impact at the individual level. It's for a lot longer discussion, which would be great, but that's sort of the quick response. Thank you so much for that question.
So thanks for the answer. I have to say I'm disappointed to say we're out of time, my apologies to folks who have put more questions in the Q&A. Then doesn't look like we're going to be able to get to all of the questions, but this has been a fantastic conversation. It's a really interesting model. I am so appreciative that you took the time to come and be with us today to talk us through this. We know how busy you are, and we are genuinely grateful that you sort of shared your time and your expertise with us, Dr. Pra, and I am thankful to everybody who came to participate and listen and engage in the discussion. So thanks to all. And let me say to folks in the audience, stay tuned for further communication from the center about upcoming events. Thanks, everybody.
Thank you. Thank you so much. I appreciate it. And I'm really grateful for the opportunity. Thank you so much.